All right, can you all hear me? First of all, just welcome everybody. My name is Wendy Vogt, and I have the distinguished honor of introducing our speaker today. I also just want to welcome everybody who's online and to let everybody know there will be time for questions and answers at the end. So please, start thinking of your questions now so we can have a nice discussion. So I'm really lucky. I work at Jhpiego Corporation in new program development, and I get to work with our Chief Medical Officer, Dr. Tigistu Ashengo. We all call him Tiggy. He is a global health physician, educator, and researcher with 2 decades of experience in public health, clinical care, and strategic leadership in resource-limited settings. He's the Chief Medical Officer for Jhpiego. He's worked in more than a dozen countries on initiatives in health system strengthening, safe surgery, voluntary medical male circumcision, maternal child health, and prevention of mother-to-child transmission of HIV. He's author and co-author of approximately 30 publications. He's one of the original founders of the G4 Alliance. And he serves on the World Health Organization's Technical Advisory Group on the use of medical devices and is a special advisor to Ethiopia's Minister of Health for the national COVID-19 response. And he's going to be talking to us about the global health security agenda. So yeah, give a round of applause for Dr. Tigistu Ashengo.
I'm wired and ready. Thank you, Wendy, and thank you everyone for coming today. I come first with message from Baltimore and DC area, people saying hi to you all. This is my first time around here and I'm excited. You have a beautiful campus area. When we first started talking about global health security, one of the questions like, is this about bioterrorism? It's like, so I'm not an expert in that. I'm not going to talk about bioterrorism, but really because I know you're a diverse group of people interested in global health, public health, health security, the threat of health issues globally. So that's what I'll talk about. And because this is a very broad topic, I will try to put some of the key things that will help us in starting a conversation. So I'd like to open it maybe once in the middle and then in the end for a conversation. But if there are some things that are urgent, not making sense, please stop me so I can also have that discussion. I hope this thing works. No. This thing work? Oh, okay. There it goes. So I'll talk about just like some background to get us started to set the stage, why we need to talk about global health security. And sometimes it's important to look at some of the historical evolution of health security discussion, because it has a huge bearing in how we understand it and how we make decisions to the future, because there are, I think, enough lessons that we can look at, and that will help me then define what everybody's talking about in terms of global health security. And I also want to make some few discussion points around relating global health security with health systems. Some of you have discussed in your class, and maybe in the end, I have a couple of questions for you all to reflect based on the session today. I have so many pictures and few texts, so I'll try to just make mention of some of the key points, but I'm sure this can be, I know it's getting recorded. If you want the slide, I can share the slides. But just to set the stage, I think it is kind of obvious to all of us living in this pandemic era that emerging and re-emerging infectious diseases are going to be unfortunately, the constant presence or news in our life. But at the same time, an important area of study and deliberation so that we can do the future a little maybe better or differently than what we've done in the past. Because if you look at all of the emerging and re-emerging diseases, all of them in the last 2 decades came from zoonotic diseases, which pretty much in my time in medical school in Ethiopia, that discussion was very scant. Even though we know that is a very important topic, it was not happening. So I am sure in medical schools here in the US and globally, that's also like an issue that needs to be addressed. And by the way, I have to say I have a good friend from the medical school that I went to here today, so I'm also excited to see him here, Dr. Gittin. Thank you for coming. And again, as you can imagine, this is also an interplay between not only the public health issue, but I think the discussion around climate, the technology evolution, and the different types of pathogens evolving due to a number of reasons that we can probably talk about, and by itself is a standalone course. But it is really important to recognize from the outset the importance of all of those things that are happening outside the health system. And this increasingly blurring of global and local when it comes to health. If you are a health leader or a minister, I'm fortunate enough to work with the Minister of Health in Ethiopia. In the past, the discussion has been, if you're a minister, you worry about health within the border of your country, but not anymore. Whether you like it or not, that's not going to happen if you're leading a health program in any given location. So that view is going to be very important. Yes, you may be health practitioners or leaders in the US, but I don't know if this is an unfortunate news to you, but you are not going to avoid a conversation happening in Latin America, Africa, or Asia in your work, in your clinics here in Philadelphia. So it is very important for us to recognize, because the forces in the past, starting from the post-Columbus era of people's movement during the plague, and then also the transatlantic slave trade, and finally the booming in international travel and connectivity is an issue for us to look at. This is just to show you the networking and the movement of people in the last 100 years, the first like 1933 versus now. It is, I think, the reality we all live in. So it is a very important thing to consider as we discuss global health security. Changing climate, regardless of where you are in the spectrum of that discussion, it's important in terms of how we approach it. Population, I think we've made it to 8 billion recently. So if we continue, we'll make it 9 and more. But as much as it is great to have a world full of beautiful people, we also need to prepare for the world to cater for and have health ensured for the people on this planet. And that then brings us to this idea that diseases that used to be far from where we live are no more, including diseases like I just took the example of here, malaria, where I studied, and most of my work is in sub-Saharan Africa. There was this idea that there are geographic locations for malaria to become common, and that people need to worry about that. But that story is changing. Where I grew up in the capital city of Ethiopia, Addis Ababa, recently started looking at some of the data, how some of the malaria has actually evolved to become really like a threat in urban places. So what we know, when I say historically, this is like a decade or 15 years ago, was true is no more from a public health and global health perspective. So working with as diverse disciplines as possible to ensure that we are responding to the changing faces of diseases is going to be important. I think you all agree, and I don't want to repeat all the statistics of, or the implication and the consequence of poor health. I just randomly selected one kind of fact from the Institute of Medicine, published almost like a decade ago here in the US. And as much as 50% company profits go to healthcare costs. Now, this is just like here in the US. It gets worse in all other locations. So if this is something that we actually pay for on a regular basis, so our future as countries, as economic entities is also under a huge threat. So the reason why we need to look at health in a comprehensive manner, whether we call it global health security, global health, or clinical medicine, is really the survival of our nations is at stake. So the cost is huge. But this discussion is not new. This is like, I'm talking about a century-old conversation around this need to protect communities. The first international conference, so to say, around health security or something similar to that happened in 1851 by the government of France at that time. They were worried about, of course, cholera and plague and other diseases. They just didn't know what the cause is, but they're worried. Obviously, the same way we're worried about, Ebola or COVID and all. But subsequently, many countries started to pay attention to that conversation in terms of ensuring safety to their own communities within their own borders. And increasingly, there was a little bit of a progress, but at the same time, the governing context of the world made it very difficult to have that mindset that is more of collaborative. So everybody started to really look at their own people. By own people, I mean in their own countries. So the second, third, fourth, fifth meetings ended up almost saying like, there's nothing we can do together, but we will try. So this global collaboration as a challenge is something that started from the very beginning. But at the same time, it has given some positive momentum, even though it has taken it probably a little longer than we all want to, leading to become one of the powerful momentum for the establishment of the World Health Organization in 1940. Of course, there were a number of other incidents and movements that led to for that establishment, but that recognition for all of us to have an international entity to look into the well-being of everyone wherever they live was obvious to people. The question is the how. That was the most difficult part for many. So the World Health Organization used some of those draft materials developed over the years to come up with what is called the International Health Regulation, which is a change of the initial International Sanitary Regulations to International Health Regulation in 1969. And then after, again, many years, in a typical, unfortunate way the UN works, it has taken probably more than 3 decades to get to a point to develop what is called the International Health Regulation in 2005, which is currently the document that all countries subscribe to and use to define what public health should look like if we have to operate in the global space. So this is just to give you like a perspective of what the history or the evolution of IHR, you may hear it, or International Health Regulation is. I know this is tiny, but this is, again, the lower part is the US contribution in moving the discussion around health and health security for the world, as opposed to just your own country. Since 2005, that is the International Health Regulation, there were a number of conversations, but it was very difficult for countries who are used to this idea that you need to build your health system by looking at your health system building blocks, as it is called by the World Health Organization, to go beyond those to really like collaborate with neighboring countries or neighboring regions, or for that matter, the whole world. So there was a need to have a different kind of mindset that pretty much expands the pie. And that's when this idea of maybe instead of just a health system for one country or a public health system for one country, this idea of global health security for all of us should come. So this is like, again, a very rough way of how this idea of global health security came to discussion. And the International Health Regulation had identified key areas that countries need to invest on, countries need to look at and measure. That made all the countries to subscribe to and sign in one of the World Health Organization's assemblies. Well, all of these things are nice, but one of the things they mentioned is if the health needs, like we said, is becoming a lot and diverse, and in fact, much difficult to control beyond the health system, then we needed to have a structure that brings everything together, at least from a leadership and a policy perspective. That's why the National Public Health Institutes started to become an important institutions to lead this conversation, not only in one's country, but in having that interaction with another country. So pretty much as the building or the foundation for an international collaboration and discussion between the National Public Health Institutes, such as the CDC or HHS we have in this country, as well as many other countries, similar institutions, to come together and have this conversation. So this is how the idea of global health security came with the with the intention to build strong and resilient public health systems that can not only respond, but prevent, detect, and respond. I'm sure you've heard this several times, especially during this pandemic: prevent, detect, and respond. So from a global health perspective, this was the kind of like a mini framework, if you will, that helped countries to look at, okay, what can I do? Yes, there are a number of things that everybody's asking countries to do to prevent disease or to tackle the challenges. But if we don't categorize them in a way that pretty much mimics the biomedical response, where we do some prevention work, some early detection and response, it will become a very difficult framework for us to implement. So that was the idea, was based off of previous experiences, this idea of prevent, detect, and respond for infectious diseases that can be versatile enough to encompass all other health threats was discussed. And of course, then prioritization was an issue. You go to any country and you talk about health issues and how we address health issues. Wendy was talking about earlier, like Wendy and I were in Rwanda for a certain work, and you talk to the Minister of Health in Rwanda and say, like, what kind of health intervention should we implement urgently, like yesterday? And the list is long. It goes on and on and on, and it's true for any other country. So what are some of the parameters in terms of prioritizing was the discussion? So global health security tried to prioritize into or focus in around these key areas, such as emergence and spread of new infectious diseases. It's linked with an increasing globalization because that is kind of a force that's proving challenging to stop or change. We can have ideological differences of how fast, how slow, how horizontal it should go, but it is nonetheless a force. So how do we deal with that environment? And unfortunately, all the great successes we had in the past in the form of different antimicrobials are now becoming the #1 challenges we have in infectious diseases in the form of resistance. So a problem that hasn't existed before the origin of antimicrobials, which we're all proud of. When I say we, all human Homo sapiens, now is a new problem that is happening in front of us. So drug resistance and also either accidental or deliberate release of pathogens becomes a constant threat. So if we can address a health security framework that at least touched upon this, I know some folks are from surgery group. I want to draw some parallel. The global surgery movement, when it started, there are at least commonly performed procedures. There are more than 5,000 of them in many of the countries. So the first question, which surgeries should we prioritize so that we can do them well? It is very difficult. In some places for a particular surgery, you may have one specialist per country. And it will be very difficult to make that kind of prioritization. But the data seems to show that if a smaller hospital, say something like a district level hospital or like a county hospital, if you look at the data, it shows that if that hospital can do basic, for example, orthopedic repair and some acute abdominal management, like either appendicitis or intestinal obstruction, and can safely provide cesarean section for delivery, that represents close to 80% of the emergency surgeries, and the surgeries are actually in those facilities. And that kind of shifted the discussion in global surgery. If you can make sure those happen, then the health system will benefit through that. So that idea of prioritization was also something that the global health security wanted to use. So there is a global health security as a concept, but now once we agree on the concept, it has to have its own movement. So now this is our agenda. So what does the global health security agenda? Again, this now pulls all the national public health institutes that came together to put a clear roadmap on how we do this. However difficult and challenging it is, how do we do this? What I just said, I am sure you all agree, is all nice. But until you're very clear on what you're doing, what you're measuring, and where you're headed, it ends up being a nice conversation. So that's when this idea of a global health security of course, primarily led by the US Centers for Disease Control, working with the World Health Organization, came to play. And it made it very clear for countries that this is not a completely new concept when it comes to health system, but it's really, again, expanding the health system building block, but in either a regional or global scale. So it may be the same in terms of its core nucleus, but as it gets bigger, the interaction and some of the complexities would come with it, but inherently its DNA won't change. A health system in a global scale is how the global health security wanted to look at the GHSA. So of course, like any other agenda, they wanted to put the timeline on what we want to meet or achieve. But of those, the key questions in the global health security agenda that needed to be addressed was, yes, countries already struggle with health financing in their own countries. It is so important. It is the #1 political issue for any country in the world. So on top of that, now we're asking countries to come together and finance probably something that is outside your border. Will that be sustainable? Is that going to, again, drive this idea of charity and donation again and again? If we're all at risk and if we all benefit from an intervention, we need to have a sustainable way of everybody, contributing their share and having a sustainable financing mechanism. So that was #1 in the agenda. The other one is collaboration. Obvious to say, but in terms of actual implementation, is one of the most challenging concepts because some countries may have all the goodwill and all the materials in terms of collaboration around health, preventing diseases from crossing borders. But the same countries who are working very hard to prevent disease are also having some geopolitical interest that will really put them at the other side of the table. So how do you balance all the other needs that you have, but at the same time ensure that you have some unity in the way you ensure health? It is easier said than done, but somebody gotta do it. And in this planet, we're the ones who are living, so we have to really do it. So that is the idea of collaboration that came. Information sharing. Again, we're in this era where information is readily available for most of us, but at the same time is one of those really important resources that is heavily guarded or used in many different ways to actually shape the conversation. So how are we going to do that information sharing for the betterment of our collective self without endangering my group or your group or this other group? So those entry cases between these good ideas and when they come into interaction globally became important. And finally, is the issue of accountability. If you grow up and work and become a leader in Tanzania, you are primarily responsible to the people who elect you in Tanzania. That is how the world works. But when we talk about global health security, your accountability is now going to be a little bit diffuse. You're going to also be responsible or accountable to what is happening outside Tanzania. So what are some of the legal frameworks or other opportunities for you to actually open up, but at the same time protect you as well as make you accountable when it is beyond? I'm not saying this is like an easy question and everybody has an answer, but this is something we need to work towards. But that is what the Global Health Security Agenda identified as difficult topics to be resolved if we want to change what happened in the last 100 years, because the progress was slow. Usually, when you come from public health, like I think most of us here, and health, I think it is easier for us to define the technical side of this work. So we can really talk about some of the technical priorities for global health from a prevention, detection, and response. But we also need to recognize the reason why I was talking about all the other factors is as we do those in our health, in our clinical work, in public health work, we also need to open up a little bit to look at what other disciplines, be it the legal system or the other social scientists, are playing in protecting the health of our communities. So this was an easier part for the public health team to come up with technical priorities. But we needed to also, as it is true in any health field, you don't do well what you don't measure. So this idea of creating a theory of change on what we measure and to really help us understand what the path was a very critical one. So at Hopkins School of Public Health, the Health Security Department came up with a suggestion, which they call the theory of change, where they said, we need to do an assessment. We need to be very clear on what we assess. We need to agree, because now there is an international health regulation. As a standard, we agree, but we also need to have a mechanism to measure it. It's only when we measure that we will be able to clearly communicate with our own country or a neighboring country or any other country who work with us to say, this is where you need to work harder because I'm putting a lot of effort in here, but you're sleeping there. So that makes the conversation objective. That also removes this idea that a certain group of countries or people are more powerful by their very virtue than others, so that the conversation is objective and not like a historical power dynamics. So measurement becomes critical one. And I want to ask a question around that maybe later. So when that discussion started to like press the World Health Organization and all of the countries, they developed what they called the Joint External Evaluation Tool, where you can do your own self-assessment, which is great. But as you know, if it is like something that comes to an international space and going to be debated and it influences resource, there was a need to do some degree of validation. So the agreement was to do this kind of evaluation related to the international health regulation, not only by yourself, but by external or unbiased group of people to come and assess where you are. The idea, again, is to assess where you are, give a clear recommendation on where you need to be in what period of time. And the most recent tool was published last year, the Joint External Evaluation. And I think that is now helping in really putting some of the issues quantitatively. And like I said earlier, how we divided the prevent, detect, and response. Beyond prevent, detect, and response, health security is an issue of a broader contextual discussion. So at least the Hopkins team originally talked about adding the overall health of the community, the overall health system, as well as the norms on how health is provided, perceived, and utilized as an important factor in the calculation, as opposed to just like basic indicators that people need to measure. Because norms, as you'll agree, are different. The way health is perceived, the way health is utilized is different in different communities. This is not a question of right and wrong. It is just a question of different. So different groups need to be measured with those different tools as opposed to one tool works for all. So all those ideas were included. The next one was the issue of risk. We can't assume every country is of similar risk, whether it is environmental challenges or the zoonotic spillover, depending on where you are, depending on your animal and environmental and human condition, that risk differ from geographic location to geographic location. And we need to account for those differences in risk into this assessment so that you have a clear idea of where these countries are. Otherwise, if you use the same kind of measure, obviously the result will become a biased one. Because for some countries, by default, it will give good result. For some countries, a terrible result. So we wanted to avoid, and that is, again, the lesson from 100 years. And then it gets complicated. The technicality of global health security becomes boring and tiring because now you're going to measure everything, including every interaction. When is the minister of or the team within the Ministry of Health interested in infectious diseases is having a meeting with the Ministry of Finance or Ministry of Agriculture? And to what end? Now we're becoming very granular. This is where the biomedical thought process helped, at least in the discussion in global health security, where we're getting granular and granular on what to measure. Is it nice? Yes. Is it difficult? Yes. But again, like I said, global security is that difficult concept that we have no other option but to do it. But we needed to be very methodical on how to do that. So this is just a sample of one of the sub-indicators, and it goes on and on and on. The reason why I'm really like delving into this measurement and that telling you that this is wide is also to call this attention that it is not only people who are in the health system that needs to be the actors. Now this is overwhelming. We should have this opportunity to say, listen, we want to protect everyone. We want to do whatever we can, but we cannot do it alone. And it's not just like a gesture, but it is a reality. So somebody else from other disciplines need to also join hand and do the measurement. And this is really a way of looking at a bottom-up approach for forging collaboration, as opposed to calling a meeting and begging people to collaborate on a good idea. So really laying the ground for a work that actually fosters collaboration, as opposed to collaboration fostering or forcing people to work together. So all of those measurements currently, I'm sure you may be curious, okay, so we have all those tools, have we measured them? Yes, so there has been, so the Global Health Security Index came as a result. So those 6 things that I talked about, overall prevent index, detect index, because it helps us. At the end of the day, if we can summarize to a summary statistics, it will be easier for us to have the same conversation in a clear way. As you can see, I don't know, it's very tiny here. So it is kind of obvious, but also unfortunate. There is no single country in the world, high income or low income, that is really at the top when it comes to achieving a decent percentage on the health indices we've identified to protect the community. Now, will this make us happy? No, because I'm sure we always expect that at least there will be one, shining light in this dark to show us this is the example so that we can follow. In public health discussions, there is always this idea of Costa Rica would come. And in teaching, everybody was like, what did Costa Rica do? This is so interesting. How can they achieve by spending much less than the US, but getting the best out of health? Those conversations are important and interesting, but at the same time, a little bit misleading, because what I said earlier about risk, the types of risk, the type of context, the type of norm is different. That cannot be generalized throughout the globe. And now when we start to really address those challenges and look at the statistics, this is where we have that sobering statistics, like none of us are doing well. So if we have a disease, an infectious disease in the Democratic Republic of Congo, it is a problem for all of us. If we have an incident happening in the middle of the United States, it's a problem for all of us. Or in Wuhan, China, it is a problem for all of us. But that requires a kind of mindset and a little like going outside what the last 100 years talked about health security. You look at the progress, like I said, now we're measuring, whatever I say as a good idea, when we measure it, yes, there is a slower progress, but we're still far from the target that we had for ourselves. You look at North America for like catastrophic biological events. I just took this as an example. Even if here in North America, the US and Canada, we do well, 99%. We won't be safe if all other continents continue to perform this way. So sometimes the statistics need to be looked at from that global perspective. I know I'm preaching the choir, but I just want to make sure, like I make this point again and again, how important it is we have a different mindset that looks at global health or the health security of the world differently. Okay, I'll pause here. Is this making any sense to you? Do you have any burning question or anything that you wanted to raise before I talk about the second part? Do you have any question in the chat room? Sorry.
I have a question about the global health information sharing system. Mnokse said, who will have control on access to this repository of data, given all that has transpired within the last couple of years coming out of Wuhan and so forth, or what did not come out of Wuhan?
Thank you very much for that question. So the global health information sharing system. So we've agreed, we've set up as an agreement that that is an important thing to have. But the question is, who is leading that? Who is doing that, given what happened in the last 2 years? So at least from what I know, the World Health Organization, as part of this conversation, is trying to bring different groups who are not, who are not directly favoring one group over the other, to come and look at it objectively. That is the right answer. Is that the reality? That's a completely different perspective. Why? Because we are, like I said, we are in that process of really having a new mindset. So global health actors who are leading some of this global thinking and global information gathering come from all over the world. But their work, their research, and the way they are influenced may be affected by a particular or a dominant group. So that is where we need to have like that constant opportunity for us to have ways to make this transparent. So as much as it's a simple question, it's at the same time, I think as you've alluded to, it's a very complex one. Because again, it continues the 100 years of story. All the 100 years meetings happen in Europe. All like the international sanitary regulations, even the evolution of international health regulation, happened through a mindset and a thought process that came from Europe. So yeah, obviously, because of that past history, there is a tendency for information to be, again, dominated and driven by the global north, as they're sometimes called. Does that need to be addressed? Yes. Sorry, that's a long answer to your very direct question. I hope it makes sense. So it is nice to have these conversations, but the question then is, what do we do? Like, how do we get our chunk in here so that we can at least do our part well, so that it fits into that bigger picture? Because all what I talked about was the bigger picture. And I just wanted to give, just to showcase my own example working in this organization where I work with Wendy, on how we took some of the pieces while having the bigger picture, as discussed earlier. One is really looking at regional approaches. We started to look at regional approaches because of what I said about context, norms, and risks. Working in West Africa and working where I come from in East Africa is a completely different story. I know for the rest of the world, it is Africa, but the context between East, South, and West Africa is different. But at the same time, you go to any given country, you can then divide that country into other groups, further and further and further. So you need to strike a balance of not really having this like multiple groups, but at least important groupings of countries from a risk, from a norm, and from a disease or a people's mobility perspective. So we focused on regional approach because especially in West Africa, where we were there during the Ebola outbreak, we were able to see how actually people move from one country to another country to have the disease reported on the news the next day. That is the reality in West Africa. So we wanted to approach it, one, from a context perspective. Second is building the capacity of the staff or people that we work with. The health system talks about workforce is one of the most important, one of the key components of health system building block. But the health security issues made it simply worse, because now you are not only doing something in your own facility for a patient or a client who is sick, but you have to also have another mindset to ask questions of where that person comes from, what kind of context, from which country, what kind of food, which kind of transportation. This adds a layer in how we diagnose conditions, pretty much that detect piece. So we needed to have a cadre of healthcare workers who can do surveillance, detections, rumor investigation, and then all the way to when things break out, the emergency management. You can do surgeries when you have an OR day dedicated to you on a Thursday, when you have a pre-OR list coming to you, you have time to review them, read them the previous night, prepare, look at your YouTube, your book, and get ready and operate. That is fine. But when it comes to an outbreak, we don't really have that kind of time. So how can we build that capability to respond pretty quickly? The emergency discussion we're having is not the type of emergency discussion we had in the past. So it's a completely different skill set. So that is also one of the things we looked at in this conversation. Prioritizing interventions. Like I said, prioritizing interventions because of, again, the contextual difference between countries or the risk difference between countries. WHO oftentimes, as you know, comes up with a technical guidance without any commitment to say this is true for every country, saying based on the available evidence, this is what we think needs to be done. But at the end of the day, you make the decision which ones to apply where and for what purposes. That requires a certain kind of thoughtful prioritization. Unfortunately, global health historically was driven by a conversation that happens far from places where this is implemented, including Geneva, where making decision on paper is easier to say, okay, now for this disease, this is what needs to happen in Asia and Africa, or in Latin America, or Europe and the USA. But that translation becomes very difficult. So prioritization needs to happen at a regional or at a country level and feed that information to the normative agencies like WHO, as opposed to the other way around. Now, that is another mindset change because it is, again, a power play. Because World Health Organization, as much as it's a great institution looking at evidence, there is also a certain degree of power it has in shaping how countries do their work. Not only through their technical guidance, but by virtue of their sitting on the table to say what needs to be done, they were able to mobilize what resources to be implemented. Which means if you are in a poor country like the Kingdom of Lesotho in Southern Africa, you have no choice but to sit and wait for WHO to recommend something and another country or financing mechanism to fund it and so that you can implement it, as opposed to the other way around. And I'm not saying this from a very negative angle, but I'm just saying like this is the reality that we have that needs to change. For global health security, that kind of conversation needs to happen. So partnership, since we started global health security, this is only like a sample of partnership. Like I said, collaboration, a good idea. Partnership is a great idea. But if you really, in reality, if I want to do this partnership, where in my current responsibility, I'll have to be on a meeting for 8 hours every day for 365 days. So as much as it's a great idea to collaborate, but it's a taxing, demanding work. So we need to find a way where the traditional way of collaboration, traditional communication need to change. So that it's not like institution-based collaboration, but a different form. And I don't know the answer, but I want to hear from you what that might look like, looking at the future. We've made some strategic investments in our work in some of the countries, including some investment for early detection using technology. So we've tried technology integration in some localities to do advanced analytics happening in smaller geographic locations, as opposed to the historical trend of you have a technology and has its own pathway to get to that smaller district area. The fact that we have the opportunity that we can connect with many geographic locations at once, we can also use that as an opportunity to change some of the discussion. The same way the mobile phone technology transformed the way healthcare and communication happens in West Africa, we can use technology as an opportunity to do strategic investment so that there is that bottom up. And finally, I wanted to bring this idea of whatever I talked about, how a regional or a continental institution such as the CDC Africa, I selected that because that is where I work most of the time. I work in one of the working group with CDC Africa. how the concept I just discussed are encompassed in what CDC Africa does things, all the way from surveillance, this is surveillance in some geographic areas or countries, to setting up emergency response. And when I say CDC Africa, it's not an organization that is like that old. It's probably what, 6 years old, it's a toddler, lots to learn. But that idea of having leaders from the region and also looking at sub-regional leadership as an important way of looking at global health is coming up. And the first institution to oppose the work of CDC Africa, now I'm just being a little political here, is the World Health Organization. Because WHO said, like, why do we need to have CDC Africa when we can do all of this? They're being nice, but at the same time, it is like something that's built over, again, century, to say that countries who are like usually in low income don't really have the power, don't really have the resource and the capability to do some of these things. Nobody says that directly, but you can have the technical words to say it. So that caused a little bit of a challenge for institutions like this to grow, do well, and be accountable. So what makes it very difficult in this conversation is when a global institution pushes an institution like CDC Africa to do what we just discussed from health security, that pushback is perceived by countries in Africa that support it as a complete pushback, so they become very unrealistic as well. So CDC Africa won't be accountable because this is now our institution. So whatever it does, we'll just have a blind eye. Makes it very difficult to be very objective, to take even your own institution accountable because you're trying to defend it from the global force. I bring that as a very simple concept, but it is a very important concept from a global health security perspective. Because sometimes what we consider as doing the right thing, a reasonable thing at that point, unless we have enough time to reflect and deliberate, it actually will set us back and slow the progress globally, even when it is seemingly the right and the patriotic thing that you do. And I think we've seen that with the vaccine distribution globally. So as an example, all the emergency, this is just pictures of emergency operating centers that we work with countries to set up during the pandemic, just to show you some of the pictures. In some places, we hear of an event, so we have an event-based surveillance or do a rumor investigation in a particular region, deploy the team of people who are trained to do the investigation, with the idea that it's not only about our country there or our region there, but it is about the world. So we try to infuse that, the capacity building, like I said, workforce, all the way from clinical care down to community is something that we are working with countries to prioritize. In Mozambique, we work with the Ministry of Health and the National Public Health Institute on an information system. This is in Portuguese. That really, again, looks at connecting animal health, the environment, and human health so that anyone at a leadership level will have information accessible to make an informed decision, as opposed to having endless meetings between the Ministry of Health and Ministry of Agriculture and Ministry of Finance to solve an outbreak that doesn't wait for meetings to be organized. And how can we also have responsible use of technology is something. So I personally, like I said, participated in the COVID response in Ethiopia because that's where I am from. And I was supporting the Minister of Health. And there was a time when mechanical ventilators were an issue, right? It's true everywhere, including here. But the mechanical ventilators, there were some mechanical ventilators that were available. So at a political level, a decision was made for mechanical ventilators to be like distributed very fast to all the countries, including to Ethiopia. I was there, part of doing the calculation, looking at the mechanical ventilators. But I knew 90% of those mechanical ventilators will end up in a storage because 90% of them require an oxygen sensor. They needed a person to actually do both troubleshooting as a preventive and maintenance on a weekly basis. I know those hospitals. We don't have those. And when we had this conversation, it's like, but this is a political decision. It needs to happen. Now, a good idea, but it does really go down to save people's lives. Now it has kind of overcrowded some of the storage facilities in some of the facilities, making it very difficult to actually provide services like cesarean section. The reason why I'm bringing these stories is like the importance of like stepping back a little bit and trying to have the, you know, the longer and the bigger view before we make some commitments. Final few slides. Because of this, I don't know, getting that you may be aware of this publication. 3 weeks ago, there was a series on One Health that was published on The Lancet that pretty much talks about what I mentioned. What can be done? So this is history. This is what is happening. I think what is of interest for you all, and I believe for myself, is like, so what is the future? Knowing what we know, seeing what we've seen, what should be the future? So what are the things that need to change? So in this Lancet paper, they try to talk about what are the different ways we can change what I just said and have a deliberation. I took from the Ford's paper that was like explicit enough in sharing recommendations to share with you. And I can share the paper as well for you to read leisure time. There are 12 recommendations they came up with. But I can highlight maybe 2 or 3 of them. One is recommendation number 2. Especially when it comes to health, this idea of collaboration with non-health actors here in the US, because of many years of experience, it was good. I think there is that recognition. But the reality is in many places, these are living in completely different kingdoms. Health and social sciences and the legal systems are living in a completely different kingdom. So that makes it very difficult. So from the outset, before you leave training institutions, having that opportunity to spend some time, collaborate with people from different disciplines is critical. So that's one of the recommendations. I know I'm running out of time, so I'll just stop it there. We'll leave you with these questions. So since we've agreed how to move from national to regional to global for health without borders, and resource and power imbalance as a moral and practical challenge. How do we deal with that? There are a number of publications out there. And this is something that I think we are collectively learning in global health security and global health in general, but those might be some important questions. But I know this is an overwhelming concept for any ordinary individual like myself. So I want to leave you with this last sentence, like people like us here who are interested to listen here today, wherever life takes you from your discipline, we can really play a huge role if we really look at how we do things, if we combine our assets and opportunities, if we associate and cooperate. Easier said than done, but I think that is what I see as a hope. And if you look at all the publications, they seem to indicate towards this. Thank you very much for your attention. But question?
Just a reminder to our folks who are joining us virtually, if you have any questions, can you please place those in the Q&A box at the bottom of your screen? Thank you.
Thank you very much for that lovely presentation. With the last slide, I share the same sentiment, more especially at this time when we are saying that information sharing is quite critical when it comes to early disease warning and detection. The thought that I'm having right now is that different countries as it is right now, they are at different levels of digital health maturity. And what we tend to do is that each country tends to focus on improving its own public health data infrastructure. But what we need to bear in mind is that no matter how good my data infrastructure is, as long as other countries are still remaining behind, we are not safe. So where you are, the organizations that you work with, I was just wondering, are there any deliberate efforts or strategies for member nations to work together in improving their overall global digital health infrastructure? Thank you.
Great. Thank you. So yes, so from our example, even like the most recent Ebola discussion in Uganda, one of the things that our teams in Uganda, DRC, Cameroon, and Chad, and Tanzania, and South Sudan did was to really plan together for Uganda's response. You know, that's what we're trying to do is like when you plan something with other countries. So you rightly pointed out, every country wants to have its own digital health strategy vis-a-vis a regional digital strategy. So even like surveillance, rumor investigation, and border health as least as a starting point was something that we did in Uganda. So everybody is concerned as if it is your own country. So we're trying to get that idea of ministries of health or representatives from all of those countries to come together and plan for the Ebola response. Historically, yes, you do a lot of work to prevent it from coming to your country because that's the mandate, but going beyond that to actually plan, even if you are 2 countries removed from where the source is something that we're trying to infuse. So we started some early modest work. When the result comes next year, I'll share.
Thank you. I have 2 questions. One of them is really broad. I'm just curious that the focus on global health security really is focused on infectious disease. And I'm wondering if you see this definition or this approach ever expanding to include non-communicable diseases, lifestyle diseases, diseases brought on by environment. Because when you look at the image there with planetary health, really you see the environment coming into the conversation. And I'm wondering if, in the context of health security, you see an expansion of the view beyond just infectious disease. That was one question. And the second question, unrelated, was generally, how do you bring other disciplines into the planning for health security? So I'm just thinking back to when the Ebola outbreak happened in West Africa. I read something about how anthropologists were brought into the conversation to understand where people were moving, right? How they could pursue safe and dignified burials and sort of have behavior change that would stop the spread of the disease. And so how do you bring other disciplines into the planning and response?
Thank you. Wonderful questions. So I can share the experience I had in terms of bringing other disciplines, because we agree it is an important principle, but it is challenging, right? It is challenging to actually make it happen. But one critical thing, at least what we've seen with the COVID response, was really getting the leadership of the health system to actually recognize that. Because who comes to this conversation, unfortunately, is decided by people who are at a leadership level. They pretty much create a certain kind of information asymmetry, if you will, when it comes to response. So if a leader leading health system is actually supported to recognize the importance of multidisciplinary team, not only will they bring people to the table during this time, but also their Ministry of Health, as an example, their Ministry of Health will have a different look, including having the legal department not to protect just and also write laws for healthcare workers only, but the legal framework for their interaction when it comes to health. And there are some countries that have done that kind of elevated inclusion of other disciplines, but it all goes back to leaders recognizing. So I think one of the things we can invest more is getting the leaders to recognize the importance of, when we talk about health, all other disciplines are equally important. To your first question, yes, everybody started with infectious diseases, one, because that is the prevalent condition we have, But I think I tried to give an example of the global health surgery discussion. At some point, we needed to prioritize, it looks to me. So if you look at all the burden in global health, yes, environment as an overarching issue needs to be there, needs to have that conversation. But all of the things that we're currently dealing with in a short to medium term are infectious diseases. So if we start working around some of the key issues around collaboration, accountability, and finance around infectious diseases and build a momentum, then the reality of expanding it is going to be probably achievable. But the recognition is there. But I think we needed to start somewhere. And I think the easier entry is the infectious diseases. That's how I understood that.
We do have a question from our online audience here, from Andrew. So my impression is that you feel that the WHO has room for improvement. If so, what do you feel are the top 1 or 2 areas for reform for the WHO to enable it to play more effectively?
Yeah, that's a very good question. And I invite anyone who has ideas to share as well. But again, like I mentioned earlier, yes, WHO is a great institution, but has a lot to improve, a lot to work on. And one distinct thing that came, or the pandemic made clear, is I alluded to earlier, is really empowering regional institutions to succeed. Because WHO oftentimes comes as a competitor, or if there is a strong local institution is up and coming, unfortunately, the World Health Organization feels threatened. But that you would see that if you're a WHO person, I think it is a success for you to become kind of irrelevant, or at least your task is reducing if you have a stronger institution. At least that is what is there theoretically. But in reality, that's not what is happening. So one area of improvement that I think many countries or regions in Africa and Asia are pushing is for WHO to be comfortable, to be irrelevant in some places and relevant in others. WHO could have, negotiated the vaccine distribution much strongly and consistently than having the guideline in Mali has a particular shape. So I think it's that level of comfort to really let or delegate power is going to be critical for WHO of all other things that WHO need to work
for that. Are there any questions from our audience, both here in person or virtually?
You said you work with the Minister of Health in Ethiopia. I just wanted to ask more about that experience, because we are working on briefs for different ministers of health in different countries that in one of our classes. So is there a approach that you went about when you did that? Is there a lot of pushback because they have that responsibility to their community, and they will get a lot of criticism for some of the actions they take? So how does that process work for you?
So engaging with ministries of health. I think for me here, it may not be fair to say this is how you do it, because I'm originally from Ethiopia. So I have enough social capital to work in that ministry particularly, but I've had the good fortune of working with ministries of health in Rwanda, in the Kingdom of Swaziland, sitting at the Ministry of Health. I think from a public health perspective, it's always very important to recognize the question that ministries want to address. Because we go to countries, especially if you're a global health actor, you go to countries with some preformed idea or statistics that can back up your claim when you go to a given country. So it's always important to have that as an important resource, but really to start with actually listening and understanding what the question is, and also taking some time to actually validate what the data that you have and what people say on the ground. That is where I think, in my mind, becoming a true scientist or a true health worker is to have that opportunity to pause and actually ask questions, learn from what people tell you. When I say learn, people can tell you, whatever they feel, they come from different angles, but you should have I think the interest to ask questions, probe, because not all of that is true, or not all of that is bad. So really making sure that you have that balanced mindset, like the scientific paper that you take, also come up with their own biases. So really trying to understand what science is telling you, what the reality is telling you, and try to become as much as possible that I think in public health, the equipoise is going to be very critical in engaging with ministries of health, at least from my experience. Right, Katina?
I just had a question. So you spoke a little bit about kind of the competing interests of different countries when it comes to health security, health informatics, and surveillance. Are there times in your professional life where you've seen the interest of one country in terms of health security really not aligning with the interests of another country? I know at times people can be scared about disease spread or what happens if you spread resources too thin or aid. So I just wanted to hear a little bit about your experience in that space.
I don't know, Wendy, you can also talk about this because recently we had this discussion in the border between Rwanda and Uganda. By its very nature, you know, there's no border. If you're living in the Ugandan border close to a health facility in Rwanda, you go to that health facility. There is a long stretch of line between Mozambique and Malawi. Like on the road, literally as you drive, one side of your car is in Malawi, one side of your car is in Mozambique. And people do interact and go to health facilities. But then when an outbreak started, because of the countries, I think need to assert their own capability in responding to their communities, they had to prevent their own citizens from going out and, for example, access services in Uganda, in Rwanda, because if they do that, the meaning is different. Even though it's about protection, the political message was different because there were people who are sitting there and waiting. You see, you're not able to cater for Rwandans, now they're going to Uganda. When in reality, that is something that must happen to protect them from disease. So that has created a bit of a challenge to the extent the government actually pushed for health centers to be built within a span of 3 months at the border. But that was a political decision. So those health centers are pretty much useless at this point because they answered the political question, not the health security. So those are like really like the entry cases that you find as you deal with, you know, health security issues.
I guess bearing those in mind, do you think that health without borders is the ultimate goal? Because I think that to get rid of the borders is to kind of negate some of the cultural intricacies that you've mentioned. And so I would just challenge, you know, how do you feel about actually removing the borders then?
Moving borders?
Removing health without borders is that first point.
Yes.
And so I was just kind of thinking, you know, it feels trivial to remove borders if there are so many intricacies that we've mentioned that contribute to the disparities. And so how do we remove the borders and balance the health and politics at the same time?
Interesting. Yeah, I would love those borders to be removed. I chose that quotation for particularly that reason. But like a colleague of mine in Liberia recently talked about at Hopkins at the Advanced Physics Lab about border health and changing the narrative, the concept of border health, not as border between countries, but people who live around a certain border. Now, just the framing of people living around a certain border versus border health was a significant, actually, first step where now the two countries started to look at, okay, who is living very close to this potential contaminated water source? Now, the border is a secondary, but the primary question became who? That used to be a different story. So yes, definitely there is a role. I think countries may still, you know, keep their, I don't think we have evolved to reach to that age of like borderless living, but I think we can shift the narrative, especially from a health perspective, by making the focus on the who and what needs to be done instead of where. On this side, there is a long-term goal, but also in the short term, that can happen. So we've seen that in some of the work in West Africa, and I think it's possible.
If there's no other questions, I want to be mindful of time. We're a little bit over. And with that, I want to thank you very much, Dr. Ashengo, for joining us today and speaking on the global health security agenda and enlightening us to it. Thank you very much.
Thank you very much for inviting me.